Hey group, we have a good presentation today from somebody who I've been following for a long time and who has been gracious enough every single time I've asked him for help to help me out when I ask, which is always very appreciated. But one of the things that I love about Walt is how he made the transition from being known as a myofascial release teacher, and then once he was faced with the evidence, started to change the narrative behind that, even though there was a lot of kickback, as it were, from mentors and from the myofascial release crowd. So I don't know, Walt, do you want to just talk a little bit about yourself for a minute, and then we'll get into asking questions, or kind of introduce yourself?
Yeah. I'm Walt Fritz, physical therapist from upstate New York. Been a therapist since 1985. Physical therapist. Been what I would, I can call up myself a myofascial release therapist, and although there's no licensure or whatever around that, but using myofascial release kind of as first an interesting hobby, and then what I did as a primary way of living since about 1992 when I took my first class in myofascial release. And I fell hard down the rabbit hole of myofascial release, and I used it first in home care and pediatrics, and then I started my own private practice. And around, well, it's sort of fuzzy, when you set up a table in your living room, does that count? Because that's how it was for me. I still had a full-time job, and I bought that table and set up my living room, and that was in the mid '90s. But then 2000, I kind of transitioned to full-time private practice. So I still have a private practice here south of Rochester on a part-time basis, and I also have a very robust traveling and teaching schedule that keeps me on the road quite a bit too. So that's me in a nutshell.
Nice. So I think to get the start, the thing that's always really interested me, and you and I have talked about it a little bit in the past, is when you made that, or how did you come across making the transition into a more evidence-based practice, especially when for so many years you were teaching myofascial release, and then you went, well, I've looked at the research and the evidence, and it tells me that what I'm teaching isn't, or the narrative of that isn't accurate. And
Yeah.
that's got to be, because I know for a lot of people it's almost disarming to go, well, I've been teaching this for so long, how do I make the change when this is what I'm known for?
Yeah. It was, Jamie, it was really in a lot of baby steps. I did all my training with John Barnes. I worked for John from 1995 to about 2005, 2006. And, in terms of working for him as a teaching assistant, traveling around the country and in Canada a bit, as helping him with his model. And his model is a pretty popular model, at least here in the United States. I don't know about in Canada, who's the MFR guru, but he certainly, that was my entry drug into all of this. And you know what? It worked. It's heady stuff. It's the weird part is there were times during that early period where I really thought that I was working from an evidence-based perspective, which really gets confusing because, okay, which evidence are we going to take? Because you and I hit this all the time. Like people says, well, I'm working from evidence. Look, there's evidence that says that, my chakras are not aligned, or at least there's a paper that's written or whatever. I'm making something up, right? And I don't mean to malign chakra balancers or whatever. But what is evidence? And there was a really convoluted and disparately connected evidence-based chain that MFR was taught with, the craniosacral was taught with, kind of my other training that I did a fair amount with. But a lot of what we do has what seems like pretty sound evidence that's presented. I mean, I'm guessing, I didn't go to massage school. We had massage in college, but I'm guessing that what you learn is backed by what is said to be evidence, what is said to be science, what is said to be a logical and a science-based conclusion as to what's wrong with the muscle and why massage impacts it. And that's kind of how fascial work was presented to me. I was taught from day one, our best evidence is our patient's satisfaction. All right. That science hasn't caught up to us yet. Those are two big buzzwords that just keep getting rambled around and around until finally you're kind of dreaming those thoughts where we know more than all these really, pointy-headed research-based people, because they're not out there in the trenches. They're not out there working with people's fascia, working with their emotions and all this stuff. So, I mean, I literally, kind of followed the mantra of that tribe, and I basically ignored all those people who said that we were full of crap and that we weren't really working from an evidence-based perspective at all. In fact, we weren't even using sound evidence, which just created a lot of freaking dissonance, a lot of infighting, a lot of ignoring, a lot of like walls put up and people in their silos. And it's still like that today. It really is, that whether you're a fascial person or a muscle person or a fill in the blank person, you're still existing in these beakers, all just with echo chambers going on, where you just talk to each other in your own language, and they don't quite know what we know. And one of the common stories that gets pushed around on social media about me and how I changed was that that I discovered that I really questioned all of this stuff. And that's what led me to leave the myofascial release community, which is a total lie. It's not true at all. I've never said that. What's true is the person in charge of that myofascial release community tried to control my website, tried to tell me what to put on, what not to put on, threatened me with banning from the tribe. And I said, fine, bye-bye. Rather than kind of give up my independence, or at least my voice, and succumb to what somebody else said I shouldn't do, I basically said, you know what? I've seen this happen before to other people, and I certainly saw it happen to people after me. It's like, I'm leaving the island on my own instead of getting kicked off. And honestly, Jamie, for a number of years after that, I continued to then start my own line of myofascial release training, which was sort of a mini-me versions of Barnes's version, without a lot of the emotional psycho or pseudo-psych, that whole, the word I'm trying to think of, it doesn't matter. But, the whole energetic component, I never resonated with it from the beginning. So I didn't really pack that into my class in the beginning. But what did happen is, a year before I left that tribe, I was involved with a discussion on Soma Simple, which some of you might be familiar with. Soma Simple as a website is probably a lot less common now since social media, Facebook has taken over. But back then in the early and mid 2000s, Soma Simple was basically a bunch of neuronuts, right? People who felt that everything must and can be explained from a neurological perspective, and basically thought that us fascists were full of it because fascia wasn't what was explaining it. It wasn't accurate, that it was the neurological narratives. And I don't know that I had ever even been on Soma Simple until I got word that they were doing what they termed a deconstruction, air quotes, deconstruction of myofascial release, and that they were dissing my mentor, my work, my colleagues, and therefore myself. So I went on there being the kind of the big boxer fighter bodyguard that I look like, right? And I went on there, and what happened was about 6 to 7 months of just ugly stuff, where name calling, at least on my part. Some of them were probably a little bit more reasoned than I was, but no one was really listening to each other's side. I brought on a couple of my MFR friends, and they sort of helped me fight the fight. And anytime folks like Diane Jacobs or Jason Silvernail or Barrett Dorka would put something out there, instead of actually reading it, instead of actually trying to comprehend it, all I did was basically regurgitate some of those really disparate threads of pseudo fact that I was taught, to say, no, here's why fascia is important. And essentially, it didn't go anywhere. I got kicked off the website numerous times for bad behavior, and allowed back on with promises that I could behave and would behave, and never did behave. So I got kicked off again. And finally, the whole thread just closed. They closed it after a while. And it wasn't until well after I left Barnes's tribe that I went back to that thread. And I went back to what had been given me, handed to me, and said, well, at least look at this. And I never did back then. It wasn't until a couple of years later when I really started looking at it. And, I kind of equate it to spending my entire life not knowing there was another language beside English. And all of a sudden somebody is giving me information in French that, I didn't understand a word of it. I didn't understand the perspective and the phrasing and everything else that went with it. So it took me a long time to kind of work through it. And, I have Diane Jacobs to thank as the only person on Soma Simple who would actually respond to a message or email from me, because I had pissed off everybody else and they didn't want to talk to me. But Diane was, at least in a guarded way, she was patient with me and helped me, as they call, say, cross the chasm, in terms of just helping me understand some of these processes and concepts in a way that I really couldn't do it well, I guess I could say I probably couldn't do it on my own. So I had a lot of Diane to thank for that. And that was sort of the opening of my eyes of evidence-based practice, even though I was supposed to, as a physical therapist in the United States, be working under the evidence-based model. You know, in this MFR world, it was sort of like this separate world. We really didn't have to pay attention to that. You know, is everything evidence-based? No. Is everything evidence-informed or science-informed? I like to think we can strive for that. But again, you hit that place, Jamie, you know this, where you get out there and people start insisting that, no, man, this work that I'm doing on chakra balancing, and I hope you know your listeners aren't chakra balancers because I keep poking at that. But you know, there's probably, you know, there probably is some evidence, or at least work that sounds like evidence to say, here's why this work is valid work for y'all to be doing. And that gets really, it gets maddening. For both sides, it gets confusing and frustrating because, you know, we all think we're heading along this path that everybody else should agree with and should approve of. But there's always somebody out there who just disagrees with us. And that's certainly true now. And what I ended up doing is I sampled a lot of people's work. I certainly sampled Diane's work. I took a training with Diane, one of her earlier trainings. I learned so much. One of the things that I learned so much of and was both really troubling, confusing, and really made me curious was the fact that when I watched Diane working with her, you know, her skin-based, neurology-based, neurodynamic-based approach, when I watched her working, it was basically, she was doing what I was doing. Only when you open your ears and maybe your brain to hear what she was saying, it was an entire different language coming out of her mouth. And that intrigued me in a way that really kind of jazzed me and got me going to say, okay, I want to know more about this. But the more I learned, the less of which I'm certain, right? I learned about the nerve-based approach, the neurodynamic approach. And it's like, I think it's a big part of why when we touch people, we create impact, we help with impact. But then I went down the psychobehavioral rabbit hole to look at some of that stuff. And it's like, boy, there's a lot of stuff coming out on why empathetic touch in and of itself in the therapeutic relationship has an effect, you know, separate from what we think we're doing with the tissue, separate from what we think we're doing to the pathology, you know. And a lot of seasoned veterans like you and I often don't like to hear that contextual factors or psychosocial factors play a big role in the outcomes that we achieve. But when you really start looking at the evidence and start looking at some of the new papers that are out there, it really questions, are we really making the changes to tissues that we think we are and that people have taught us about? I'll stop talking in a second here, Jamie, but I use this example a lot. Like if you stood across the room from 20 therapists practicing 20 different interventions and watch them without being able to hear them, right? And sure, there's differences. There are differences. Some of us work wet, some work dry, some work closed, some don't work, you know, work on bare skin, the whole thing. But is there such a difference in all that we do to say that it can be explained all those different things we say we're impacting under the skin within the body, right? Or are we simply engaging the human being from a different language, you know? And to me, that's what my work has become here in my practice in terms of what I do, but it's also become what I now teach, what I write about, you know, in the book that's coming out this fall, hopefully, knock on wood. I'm working on a master's degree myself right now because I never had a master's in physical therapy. Working on a master's, simply honing this mechanism of action from a mixed perspective and not a nerve-based or fascial-based or muscle-based or psychology-based, to kind of bring it all together, at least as a starting point for intellectual conversation and future research to say, can these mixed mechanism of actions be used instead of having all these separate walled off silo mechanisms?
I 100% agree, and it's funny. I've met Diane a number of times at the San Diego Pain Summit and had some good conversations with her. Lovely lady. I think it's funny listening to you tell the story. I've often said over the years that DNM is basically myofascial release with a better explanation. And there's probably a lot of people that would get angry at me for saying that, but it's like the way that it's performed is very similar to how myofascial release is done.
And I think, and I'm going to stop you for a second. I think that's the key, because I think if we could separate out the term myofascial release as well, it's usually thought of as our ability to select fascia for treatment, which is what a lot of fascial people are talking about and teaching, right? But if we can look at myofascial release as simply a style of engagement, it's kind of like a Chevrolet, right? It's a car. You know, we call it a Chevrolet, but is it that much different from a Ford? Now, you can get into a whole different fight there, right? But if you call the work MFR and realize it's nothing more than a way of describing a recognizable brand, right? You know, I think a lot more people, and that's how I sort of weaseled my way around with for a bunch of years. I didn't believe it was about the fascia, but I didn't want to let go of that myofascial release label, because selfishly, a lot of people recognize it, and I thought I could sell them seminars. And I'm being really transparent here. And then during COVID, when none of us had anything to do, and I revamped all my curriculum, I kind of took a long, hard look at what I was doing and what I was teaching and what I believed and didn't believe, and saw that, you know, I thought it was finally time to let go of that myofascial release label. And I just call what I do manual therapy now. And even manual therapy to some people means something. To some people, it means joint manipulation or joint mobilization, right? Manual therapy. I wish I could call it Steve, right? Steve, nothing. There's absolutely no thought of, well, what is this? That people say, oh, I think I know what that is, right? I'd rather just not trick them, but really leave them a not understanding. But I don't think I'd sell many seats at a seminar if I was selling, you know, classes on Steve, right?
Yeah, which is interesting, because the things that have been rattling around in my head lately is, I can remember when we were in school, we had myofascial release 1 and then myofascial release 2. And in our myofascial release 2 class, they taught us how to do an occipital hold and told us that we were that we were releasing the fascia around the occiput, and that's why we're having an effect. And then in term 7, we had a craniosacral class where they taught us to do an occipital hold, and they were telling us that we're altering the rhythm of craniosacral fluid and sutures in the skull. And it wasn't until 5 or 6 years later that I went, wait a minute. They showed me how to do the exact same thing, but with wildly different explanations. And to me, looking back on it now, to touch on your thing about if we could just call it manual therapy, is I think, especially as massage therapists, I don't know how it was for PTs, is that we've become conditioned right from school to believe that the best way we can help somebody is by learning a new modality, by learning a new technique, rather than looking at evidence-based practice and going, well, it tells us that reassurance, education, movement, and some manual therapy is the best approach. Whereas we have all these classes that are modality-based, and we had one therapeutic exercise course and one research course. So what if we actually changed the base education and said, well, all the classes, technique classes, are just going to be called manual therapy, and we had just as many research, communication, and exercise classes to go with it? Would we come out with that identity of being, well, I'm a myofascial therapist or I'm a craniosacral therapist?
Yeah. Well, you still have then the conundrum of, at least in the United States, and I'm guessing it's like this in Canada, we all have to take continuing ed. So the most logical form of continuing ed is to take that modality, and like, how are you going to knock all of the gurus off of their pedestal and stop spreading these lies, or at least these half truths, you know? I that's a real challenge. And, you know, I keep an eye on the pulse of continuing ed with my other educators, you know, et cetera, et cetera. And then I know over the last 5 or 10 years, the pain science movement and all those things are coming into vogue. And I notice a lot of these big educators are really starting to include concepts on pain education in their marketing materials, in their promotions, in their videos and all that. But yet they're just still selling the same, they're still doing the same stuff. They're just sort of inserting, a couple buzzwords. And I know I'm really cynical, and I don't get invited to any continuing ed providers, dinners anyway. So I don't care about ticking them off, because really it's just like, why would they want to get rid of their cash cow, especially when they've got, thousands of hours of video on DVD or whatever. You can't just redo all of that stuff. Yeah. I just think everything we do with our hands has an effect, but maybe not for the reasons that we were taught, which is really, really challenging when you've had a career full of positive outcomes from using that sort of that language, that mindset of fascia or muscle or neurokinetic or whatever buzzword or acronym you're using. why is it that we all have positive effects, and are there common denominators? And Jamie, that's where I'm at right now with my teaching and with my writing, is like, it's talking about those common denominators, and it's about therapeutic relationship. It's about the interaction between you and I. And sure, we use touch as our input, but I don't think, and a lot of the great evidence that's out there now says that the touch is not as unique as we think it is.
Yeah, and it's the confidence of applying that touch makes a big difference, right? The confidence of the therapist in what they're doing.
And how much is that confidence built by taking a tiered level training from the same instructor, right? You work your way up until you become a master clinician. So are you really able to affect the fascia the way they tell you? Or did you just, excuse me, learn a really good narrative and a really good ability to tell and retell that story so that you sound polished? And I don't mean to sound like we're all car salesmen, but a lot of our effect that we have with people is our ability to convince them about what's wrong with them, to convince them why it's necessary, excuse me, and to sound confident and knowledgeable in doing that. And I'll tell you, anytime I changed modalities or interventions, there's that whole pendulum swing from, when you hit bottom, it's like, oh my God, like I don't know what to say about this. And I could literally almost see my outcomes plummet when I was sort of fumbling with those words. But then all of a sudden, you pick up the elevator speech, and then you get the longer elevator speech, and it's like, okay, I'm on a roll now. And it seemed like, and I say seemed like, my outcomes then improved. And maybe if we can just take all that elevator speech and just apply it more to therapeutic relationships and the dynamic of what we know about human interaction, and make that our elevator speech,
Yeah, well, that's another one of those kind of rants that I've been on lately. Is I'd like for us to stop saying that we're delivering a treatment, or we're giving a treatment to somebody. Rather, we should start saying that we're engaging in a treatment with people, so that we're collaborating with them, and it's not this passive thing that's happening to people on the table where you're doing something to them. It's that we're engaging in that treatment with them and finding out what's important to them and collaborating with them on those things.
Yeah, I even use the word engagement when I teach my classes. It's like, well, okay, so we're doing tongue work, right? And in the old way that I learned it, it was called a tongue pull, right? What does the word pull, what is that mental construct that was created as soon as I said, okay, pull the tongue? What do people do? Well, they pull the tongue. But instead of using that mindset, I said, okay, take a hold of a person's tongue and begin to engage it. What does engage mean? Well, it means different things to different people, both as the giver as well as the receiver. But make it a two-way process. Make it about shared decision-making, and not the clinician as expert, and getting us to step down from our ego, step down from our education training, to allow an equal sharing of power between us is really difficult. And I just find small little things like using that concept of an engagement versus a technique, right? Because technique implies specificity.
Yeah.
And with few exceptions, the research doesn't, really shine well that our specific techniques are why we have effect. Because when you look at some studies that are out there, people are doing wildly general work and helping what you're doing with a specific technique and getting remarkably similar outcomes. Yes. So maybe it's not the specificity of what we do, and whether it's of the structure that we think we're affecting, or the muscle, or whatever it is, right? Maybe it's the fact that we're actually attending and listening to somebody and hopefully building them up so they have a stake in this relationship that we're trying to build with them.
Absolutely. Yeah, and that's, I know, unfortunately you weren't able to make it this year, but you really wanted to come to San Diego to support Joel Bialowski.
Joel Bialowski, yeah,
and all the stuff.
Joel is, I use a lot of his paper, a lot of his writings, and a lot of the people who have contributed to his, and then you follow you get spread out with all of those people talking about, the way I learned this work is that we're in here, and it's whatever here is wrong here that we're fixing. I call it the what happens in Vegas stays in Vegas perspective. There's a problem with someone's tissue here, and when we do something locally, we're affecting it. And whether it's fascia or muscle tone or a nerve or whatever you call it, it doesn't matter, right? But what Joel's work has taught me, Joe Bialowski's work, as well as a lot of other people that I'd love, if you're interested, I can link some of this stuff in the show notes. But what so a lot of these other researchers are showing that in reality, we're using the peripheral tissues as a signal to higher centers. And whether that's like a mechanoreceptor signal to higher center, or just like an alert signal, or tapping into interoception through C-tactile fibers, there's so many different ways that we catch another human's attention. And they all matter. And that's what Joel Bialowski's papers really opened the door for me to begin looking at. And unfortunately, we had a snowstorm here in Rochester, and I just couldn't make it out there. So I was really disappointed in that.
Yeah, and that's also I'm assuming that you've seen his work, but I don't know how much you pay attention to it. But Ben Darlow's stuff out of Australia, talking about the contextual factors and all those other things that play into the treatment, was some of the stuff that you've been talking about all along. But just some phenomenal research.
Absolutely. Yeah, and it almost gets confusing, and I think it's frustrating for a lot of clinicians when they're trying to cross the chasm, right? It's like, well, there's just so much fuzzy gray area here. And it's like, yeah, welcome to reality. Welcome to human dynamics. There is so much gray area, but someone told me, no, there's no gray area. It's the fascia. That's the problem. That's what you're impacting. I love Diane's, I paraphrased this wildly from the way she originally put it, but she said, here we are talking about all these different things, tissues, pathology, structures that we believe that we can reach in and affect it, right? But the only thing we know we're impacting is their skin, right? I like another one. It's like when I teach my voice and swallowing work, and I get a lot of voice clinicians in there, and they'll talk about treating the diaphragm, right? And I'll say, well, can you treat the diaphragm? And it's a trick question. And I say, can you treat the diaphragm? Not without a scalpel, you can't, right? Because when we do things that we know impact diaphragm-related dysfunction, you're working through, as Diane says, the skin suit. You're working through a person's perceptions, their autonomics, their fears and expectation. And there's so many other factors that play in there besides your ability to select and isolate the diaphragm or any other muscle in the body to the exclusion of anything else.
Yeah. Or could we work on a person with a diaphragm?
Bingo. Yeah. Could you engage that person, which includes diaphragmatic function?
Yeah. Perfect. So I'm curious as well, because I know like when I came through, I saw Soma Simple a little bit, but I know when I came through, I got really angry when I started to realize that a lot of the stuff I had been taught is not what I had been taught. And I'm wondering, like, I know that you went through your stuff on Soma Simple, but when you started to make the change and you had students coming into your classes, were you met with a lot of opposition from those people thinking, oh, I'm taking a Barnes style myofascial release course, and then you pivoted with it?
Yeah. I guess there was a certain extent. I think from in the beginning, I really tried to put a division between the way I taught the work and the way Barnes taught the work. And even before that, I guess I tried to basically kind of poach his potential students, right? Take me instead of him because I'm not him, right? And that never works, right? It never works to try and to take over another person's role like that. But early on, I did begin to try and create some divisions and say, okay, here's where this might be different. And I didn't have a strong need to have these massive class sizes like he did, because I don't have a massive industry to support with that. But yeah, you always getting people that are ticked off at you, but I still get that today when I challenge somebody's biases, when I challenge somebody's beliefs, and I get it all the time online. I'm the administrator of one of the big myofascial release groups on Facebook called the OM. And, even though I volunteered, to basically step down if people think I'm too annoying because I keep saying it's not about the fascia, either anybody else is too lazy to take over. They say, no, we are interested in your perspective. But I ruffle a lot of feathers because I challenge not just Barnes and Upledger, but I challenge everyone. I challenge everybody to look at, are we really doing what we think we're doing, what we're taught we're doing? And that, like I said, it doesn't go over well with, dinner parties for CE providers because, we're challenging their livelihood, and I'm challenging my own by being what some people feel is a jerk, but it's a role that I don't know. It seems really comfortable being that jerk, being that, the troublemaker who's not unwilling to say, is the emperor really wearing any clothes right now?
Yeah. And I think that, like, from the the practitioner standpoint, like I was mentioning about taking so many modalities in school, is that the modalities become part of our entity, right? It becomes
Yeah.
part of our personality because we see so many websites that you go to, and I'm not saying there's anything wrong with doing this, but it's I'm a myofascial, I do myofascial release. I'm a myofascial release therapist, or I'm a craniosacral therapist, or where our identity is tied to that technique. So when that gets challenged, that's where people tend to get their back up, and people start to get upset because that identity and the thing that they think they have helped so many people with over the years is challenged.
Yeah. Well, and then when you go to a CE class, and not only do we encourage you to identify yourself as that person, but use that educator's name along with your credentials to, I mean, it gets really ugly in there, but yet I bought into that completely. I had the website like everybody else that talks about, my mentors and how wonderful they were and all this stuff. And, they do good work. They teach good work. I'm not dissing that. But what I'm dissing is that rabbit hole, or the thought that it's all about one structure, one tissue, and there's only one way to do it, where it completely goes against everything that you and I witness. I've yet to see one study, Jamie, that says, okay, let's pick low back pain. I've yet to see one study that basically samples every intervention out there to say, nope, this one is the best. And if there is something that says that, you can see through it right away that what they did was they biased the study, but they just don't exist. But you've got people saying in this, I heard this all the time, that this particular form of treatment is the most effective modality in the history of healthcare. And if you think I'm crazy by saying that, it's said at every single seminar, right? How do you get away with that? It's because nobody challenges you.
Yeah. I'd like to be at one of those when somebody says that.
If you said something, you wouldn't be invited back.
No.
And it's not, again, it's from what I read on social media, that's the social fabric of a lot of continuing education settings, and it's not just one or two; it's a lot of them where you better stay loyal to the tribe, or else you're out of here, buddy. Can you go to a workshop and can you say to yourself, wow, that's a really neat way to engage somebody, right? The things we do with our hands. How can I apply this in the broader context, right? Using what I know about the human being, not just their fascia, not just their muscle, right? And I take issue with massage schools around the world that put such a strong emphasis on muscle anatomy as being more important than other things. It's like, well, then the student leaves there thinking, well, I'm treating a muscle, and muscle is why a person's having pain, etc. And muscle is part of the larger piece, but that I've got enough windmills to tilt that I'll never be able to tackle that one.
Yeah. Well, and that's it should be the school's responsibility to tackle that and make the change, but they have a vested interest, and it makes it a lot more difficult for them to make that change.
Absolutely.
Because of that vested interest.
Well, especially here in the States, where the curriculums are much shorter than it is in Canada, so they've got 500 hours to say, okay, what's important here? But it's a challenge.
Yeah.
Tom, I agree 100%. Challenging our teachers. The question was, as a child, we're taught not to challenge our teachers and our coaches and our leaders. And some of us do, and we get shut down for it. But I know in very few continuing ed settings that I took where there was ever a good outcome to really asking tough questions, really grilling somebody, right? And unfortunately, I think that's the norm. I actually enjoy when people really get irritated at me or really call me on my stuff. I just taught a class a week ago in Atlanta, and I had a fellow come who I've known from social media for a long time, and he's a massage therapist and exercise physiologist, and he came just to hear my shtick, if you will. And I love the fact that he challenged me on a lot of what I was presenting. And I love it when I can't answer a question, and I'm fine with saying, you know what, I don't know the answer to that one. I don't understand this fully. And instead of either shutting the person down or just making up a bunch of stuff and then saying next, to get beyond that, I think it's really important that we allow ourselves to be vulnerable and humble, both in the eyes of our patients, but as in the eyes of our students, if you're an educator, to say, you know what, the more I learn, the more I realize there's more to learn. To me, that's being really honest and really transparent in how this, to me, how our work should work. And it's played well for me over the years. It's played well. Maybe it's because as a human being, that's how I am. Other people don't get that or rock that humble thing as easy. But yeah, I love saying, you know what, I'm not sure about that. Let's figure it out.
Yeah, and I agree. Lots of the courses that we teach are we start out with being like, feel free to challenge us at any point in this course, because we may not have the answer, but maybe we can find the answer. And any course that you go take, you should feel more than welcome to challenge the teacher.
Right. Exactly. Yep.
Yeah. Any questions, Kevin or Thomas?
Not off the top of my head. It's early still for me.
Kevin, anything from you? You can type it in, or you can turn your mic on and do it.
I'm trying to figure that out.
Okay.
Yeah, no questions off the top of my head. It's thought-provoking stuff, particularly I guess the humanity of not having all the answers as that clinician for our patients. I think that's a bright spot to fall back on, or at least to strive for as the practitioner.
Yeah. In the one thing that I've learned that I try to instill on people who I'm teaching this work is, if you have a complex patient who comes into you with a problem and they say, well, what do you think? And you say, I don't know. And you leave it at that, they're gone, right? You lost trust, et cetera, et cetera. But the one thing that I try to do with my patients, as well as what I teach, is, first of all, I listen to their story. What did they come in with? We all come in with a story for the most part, in terms of, what happened, what's wrong, what needs to be done. The interview, the intake is so important for that, to give that person a chance to tell their story. And then for me not to dismiss that story. When I crossed the chasm from MFR to neurological based models, I basically just stepped on people's stories. If it was anything to do with the fascia or the muscle, it's like, nope, science doesn't support that, right? And I basically, I dismiss their beliefs and their experience to a point where it probably negatively affected my outcomes, or our outcomes, or their outcomes, right? So what I try to do now is listen keenly and allow their story, because no matter what, no matter how much I know, no matter how much I've learned, I've not lived their life. I don't know the whys of them. I don't know where that story came from or what importance it holds to them. So when they say, well, what do you think it is? I'll often mirror back to them what they came in with. If they thought it was, a muscle knot in their neck giving them the problem, it's like, you know what? It very well might be that knot that you or your doctor or Dr. Google talked about, right? It could be that knot that is truly, the problem. But then what I'll often do is I'll flip it and I'll give them a more neurocentric explanation, or sometimes even a behavioral, psychosocial explanation. It could be a knot like you came in with, or it could be a remnant from an injury in the past that your nervous system simply hasn't let go of yet. Now, both of those are sort of like superficial vanilla explanations. But what I really like to do is let them know that even from an expert, which I guess I'm deemed as, right? Even for an expert, that I don't know for certain, that we don't know for certain. And I often let them know, it's like, you know what? You may go to somebody else who they sound really certain that it's something. And it's not that they're wrong, but they're not totally right either. Because if you go to 10 people, you're going to hear 12 different reasons, right? Are they all wrong? Are they all right? Or are we simply taking good guesses? And what I do then is, okay, I don't know. It could be that knot. It could be a neurologic remnant. It's like, then I flip it around. It's like, okay, instead of worrying about the whys, unless you want to worry about it some more, can we turn this into now doing something that you feel will be helpful? And I use a model which is very different from a lot of other clinicians, in that my evaluation is often about getting their input through shared decision making, basically saying things like, what we're doing right now on your neck, is there anything about what I'm doing right now that feels helpful? Is there anything that I'm doing right now that feels like it might be connecting with that issue of yours? Is there anything about what we're doing right now that feels like it could be threatening or harmful? And I build buy-in like that to a point where often they'll sort of let go of that. Well, what is it, right? If it's not my fascia, Walt, what is it? If it's not the trigger point, what is it, right? And it could be all these things, but right now, does this feel useful? And it often really just quiets them down and gets them into a sense of saying, gee, I don't really know how to answer that question because nobody else has ever asked me for input. Thinking my input into the therapeutic intervention like this is that important because most people act like experts and they know what to do.
And it's funny because I thought, like, to add to all of that, Walt, is somebody could come in and thinking, oh, it's because of my fascia, and that could be an idea that we put in their head at one point. And maybe they came in for a treatment from you 3 years ago and had some success, and in 3 years you would have read a bunch of research and went, wait a minute, this isn't the same thing anymore. And when they come back,
I get it all the time,
yeah,
all the time.
You've got to double back and be like, and my favorite thing is, well, you know, the new research has shown us that it's this, or that has changed. So that's where we want to be careful with our language as well, because that could be an idea that we put there.
Exactly. And honestly, I may get a patient who I see for a series of treatments, and they came in thinking it's all about their trigger points, and they might leave thinking, Walt fixed my trigger points. I don't feel like I have to totally extinguish their belief system. If there's something within that narrative that seems detrimental, we'll have a conversation somewhere along the line. But again, I've not lived their life. Is it my role to tell them that they're wrong, or is it my role to help them move on to a better functional place? That's what I look at now, without totally stepping on everybody's toes and beliefs and egos, right? Can I still allow you to be who you are and what you believe in, and still gain benefit from the relationship?
Yeah. And that could also be playing the long game, that maybe over the next 10 treatments or however many, you're going to educate them a little bit each time.
Absolutely. Because invariably people ask us questions. And to me, that's the perfect time to start introducing this. You know, there is controversy about trigger points or fascia or even muscles, right? There's controversy about exercise, and is it all because I'm weak, and all those things, right? But those are conversations that, like you said, Jamie, they sort of unfold over time if there's a need to unfold it, you know?
Yeah, I like that. If there's a need to unfold it.
Yeah.
That's great. Yeah. So we're about 40 some odd minutes in now. So I think one more thing that I would ask is, how did you make and you and I talked about it a little bit before, but how did you make that transition into the neck, throat, swallowing?
Yeah.
Because that's a really specific niche, which is really cool.
Yeah. As of earlier this year, I stopped teaching live my classes, which you might think are more targeting the massage therapist and the physio, et cetera. And I teach primarily a class that's attended by speech pathologists, but also by voice coaches, by massage therapists with an interest in head and neck or an interest in voice, or I get osteopaths and chiropractors and some other interesting folks along the way. But back in the early 2010s, I had a blog on my website, and I don't know, I really don't know what exact blog it was, but somebody caught wind of work I was talking about, where I was working in the anterior cervical region with somebody's, cervical radiculopathy type pain or whatever it was. And we came upon an area that almost was like mutual to that neck pain as well as their voice or swallowing issue. And I just talked about that. Was really fascinating to me, almost like there was one piece of frozen chicken in there that seemed responsible for, that neck and arm pain, as well as the issue with the person had with swallowing. And what happened was I was invited to a one-of class in Chicago, Illinois, back in 2013, which was presented by the Chicago Voice Care Center. They invited an ENT surgeon from New York City who also does some research or written a lot of papers on trigger point work for voice. And they invited him to sort of do the prelude and the intro, and then me to give, 2 days of hands-on work for myofascial release for voice and swallowing. And that was sort of my entry point into that world. And since that point, I liked it. I really enjoyed that. To be really blunt, I really enjoyed teaching people who didn't have a lot of prior experience and prior biases in manual therapy, who didn't have a lot of, okay, here's judgment coming in, who didn't have a lot of bad habits to unlearn. Okay. And it was really refreshing to say, you know what, let's start from scratch and let's start touching and see if it can be helpful. And since that time, I mean, I've learned so much more. I learn more at every class that I teach, because I'm not a speech pathologist. I'm not a voice coach. I'm not a swallowing specialist, you know. But the more I teach that work, the more I learn from them. And now it's become, that's what I teach around the world, and that's what the book's about, and et cetera, et cetera. So I just spent a bunch of days in the studio recording some new content. We're putting all of the upper body, lower body, balancing the body stuff that I taught live in the past. We put that into an online content that's going to be coming out late this fall or winter, to kind of get back into that kind of blended world of PTs, massage therapists, OTs, and anybody else. But in terms of right now, this is what I teach live, is the voice and swallowing disorders.
Awesome. Do you have a title for the book yet?
It's Manual Therapy for Voice and Swallowing, a Person-Centered Approach.
Nice.
Yeah, we're the manuscript's all done. We had problem with the artist renderings. They all had to be redone, so that's taken some time, and then we have to recaption some things. And I'm much more impatient than my UK publisher is, and if it was up to me, it would have been out last year. But if it's up to him, it might not be till next year. We'll see what happens.
Okay. Well, make sure you let us know when it's out, so we can engage in it and put it out for some other people. Thomas, Kevin, any questions or comments before we go?
I don't think so.
Yeah. And I know how this works in church. Oops, sorry, go ahead.
No, I was just with that little Easter egg dunk there, you know, very excited to dive into that world. You run across aspects of that in patients and patient care, and you're left in that gray zone of like, okay,
what do I do? Yeah. Well, what's interesting to me is you know, not just in the United States, but in Canada and in the UK, et cetera, where I teach, how many massage therapists specialize in voice, and some in the UK call themselves vocal massage therapists, which is an interesting niche. And I know in Canada and the US, you're not allowed to sort of create a label like that for yourself. But in other countries where there's lower or less or no regulation, you know, you can kind of call yourself whatever you want. And I think some of those niches are really interesting, because I know voice or massage therapists, even here in the States, that are working with elite level performers. But then so are physical therapists and speech pathologists working with manual therapeutic interventions for, whether it's for treatment of voice disorders or keeping the voice going. That's just a real fascinating sort of sub niche of all the work that we do or potentially can do.
And I wonder too, Walt, because of like listening to it, and because you're working in that general area, I would think a lot of the stuff that you're doing would be really helpful with people with concussions as well.
I would think so. Yeah, you know, as soon as you say that, I go, oh, like so much stuff I've heard from the craniosacral communities about, you know, all the compression of the temporal, all that stuff, you know, that I let go of long ago. But you know, I'm sure if you talk to Diane Jacobs about gentle handling to, you know, the head, that in and of itself can be helpful. I get some concussion patients, much like you, but it's definitely not a niche that I teach to in my work. But yeah. And I know how this works too, in terms of putting this up on Facebook or wherever this is going to go. And if you've got questions watching this, feel free to type them in the questions section wherever this goes on social media, whether it's on my page or Jamie's page. And as long as I'm tagged in the original post, I can answer some of your questions from there.
Yeah. Perfect. Well, I can't thank you enough for your time. You're always gracious with your time whenever I've asked, and always willing to help out. So I can't
appreciate the time yourself, and always like to talk about what my passion is, what our passion is. So hopefully it was helpful.
Yeah, it was very much.
All right.
All right. Thanks so much. I'm going to stop.
Take care.
Thank you.